Good morning. It is Miss Dennison bringing you chapter 24. We are going to be talking about nursing management of the newborn at risk. So, acquired disorders, these are basically gotten. So, you acquire them, right? So, these typically occur at or soon after birth. They can result from problems or conditions experienced by the woman during her pregnancy or at birth, such as diabetes, maternal infection, substance abuse, prolonged rupture of membranes, fetal distress, but there may be no identifiable cause. Congenital are structural, functional, or metabolic abnormalities at birth. The most common serious defects worldwide are congenital heart defects, neural tube defects, and Down syndrome. These disorders involve a problem with inheritance, including structural anomalies or birth defects, chromosomal disorders, and inborn errors of metabolism. A lot of this goes along with genetics. So these are some of the acquired conditions that we will go more in depth in the following slides. So in utero, the lungs are filled with fluid, right? Newborns normally start to breathe with routine warming, drying, airway suctioning, and mild stimulation. They usually make this transition at about 1 minute of age. They're going to be breathing well on their own. But if they're not, if they fail to establish that adequate, sustained respiration after birth, these babies are said to have asphyxia. This is defined as impairment in gas exchange, resulting in a decrease in blood oxygen levels and an excess of carbon dioxide levels in their blood, leading to acidosis. The newborn who experiences asphyxia is at risk for the development of HIE, which is hypoxic ischemic encephalopathy. Approximately 30% of infants with HIE will die in the neonatal period, with up to 50% of the survivors left with permanent neurodevelopmental abnormalities. Clearly, they're going to because they lack oxygen. They may end up developing long-term problems such as cerebral palsy, intellectual disabilities, speech disorders, hearing and or visual impairments, and learning disabilities. You're going to review the risk factors, so trauma, injury to the central or peripheral nervous system. This could be due to prolonged or difficult labor, a precipitous birth, abnormal presentation, shoulder dystocia, forceps or vacuum extraction. Also, intrauterine asphyxia. So this could be due to mom's hypoxia, diabetes, hypertension, cord compression, meconium aspiration. Also, sepsis. From infected amniotic fluid, maternal infection, or direct contact passing through the birth canal. Malformation, such as congenital anomalies, renal anomalies, pulmonary hypoplasia. Also, hypovolemic shock, which is secondary to placental abruption, cord rupture, basically causing blood loss to the fetus. Also, medications can cause this. Drugs given to mom during labor that will cause placental hypoperfusion and or hypotension. So, hypnotics, excessive oxytocin that's administered, analgesics, anesthetics, narcotics, and clearly street drugs. So you're going to observe the infant's color, noting any pallor or cyanosis. Be alert for apnea, tachypnea, gasping respirations, grunting, nasal flaring, and retractions. Assess the newborn's temperature, Determine the APGAR score at 1 and 5 minutes. If it's less than 7 at 5 minutes, you're going to repeat that assessment at 10 minutes of age. If the initial assessment is poor, begin resuscitation measures until the APGAR score is above 7. You want that newborn to have a pulse above 100, a good healthy cry, or good breathing efforts, and a pink tongue. This is a sign of good oxygen supply to the brain. Now, the use of therapeutic hypothermia is also a promising neuroprotective intervention for newborns with moderate to severe HIE. So, cooling the body to 33.5 degrees Celsius within the first 6 hours of birth, and then continuing for a period of up to 72 hours may actually slow the progression of the HIE. Now, transient tachypnea of the newborn, TTN, this is a self-limiting condition. It is characterized by inadequate or delayed clearance of lung fluid, leading to transient pulmonary edema. The newborn will experience a mild degree of respiratory distress, requiring minimal intervention, and usually resolves within 72 hours after birth. Some of the causes: lower gestational age, cesarean birth, a perinatal hypoxic stress event, and male sex are independent risk factors for TTN. We literally call them wimpy white boys. They literally are born and they are trying immediately to die. So this, if you're gonna have a boy, just always know, if it's a little white boy, he's gonna try to kill himself when he comes out of the womb. It is what it is. Decreasing that risk, performing elective cesarean sections no earlier than 39 weeks gestation. During and after birth, the fluid must be removed and replaced with air. An infant born by C-section is at risk of having excessive pulmonary fluid as a result of not having experienced all the stages of labor to mash him. Passing through the birth canal during a vaginal birth will compress that thorax, helping to get some of that fluid out. Also, pulmonary circulation and the lymphatic drainage remove the remaining fluid shortly after birth. Reviewing risk factors as the nurse, such as absence of labor, cesarean birth, precipitous delivery, maternal smoking. These are factors that are associated with a higher risk of TTN. Within the first few hours of birth, you're going to observe for tachypnea, expiratory grunting, retractions, labored breathing, nasal flaring, and mild cyanosis. Mild respiratory distress is present by 6 hours of age. Usually respiratory rates can get as high as 100 to 140 breaths per minute. Never a good sign. Also inspect the newborn's chest for hyperextension or a barrel shape, because it's trying to move those lungs and get more space for that air to go in. You may hear slightly diminished breath sounds. A lot of times they'll have a chest x-ray. This will usually reveal mild symmetric lung over-aeration and prominent perihilar interstitial markings and streakings. Just FYI. Focusing your nursing management on providing adequate oxygenation, clearly, providing supportive care, administering IV fluids or gavage feedings until that respiratory rate decreases enough to allow safe oral feedings, because they are at risk for aspiration, providing supplemental oxygen, maintaining a neutral thermal environment, minimizing stimulation, and minimizing oxygen demand. Providing ongoing assessment of the newborn's respiratory status. And as TTN resolves, that respiratory rate will decline, hopefully, to 60 breaths per minute or less. Hopefully that chest x-ray will show resolution of the streaking And you're also going to provide reassurance and progress reports to mom and dad. Respiratory distress syndrome is a breathing disorder that results from lung immaturity and lack of alveolar surfactant, which keeps the air sacs in the lungs from collapsing and allows them to inflate easily. Without that surfactant, the alveoli will collapse at the end of expiration. So one of the big issues here, and this is why the introduction of prenatal steroids are used often to accelerate that lung maturity, to increase the development of that surfactant. And it also dramatically improves the outcomes of newborns with respiratory distress syndrome. So anatomically, that immature lung cannot support oxygenation and ventilation. Those alveolar sacs, they are not developed sufficiently, so there's not enough surface area for that gas exchange to occur. The amount of surfactant is also insufficient to prevent that collapse of those alveoli, because that surfactant actually forms a coating over the inner surface of that alveoli, and it reduces the surface tension and again prevents that collapse. So it will result in stiff lungs, those alveoli that collapse, and it can lead to diffuse atelectasis. The work of breathing is increased because that increased pressure that is required to initiate that first breath is needed. Hypoxemia and acidemia result, leading to vasoconstriction of the pulmonary vasculature. Right to left shunting occurs. The most common risk factor for the development of RDS is premature birth. Additional risk factors, C-section, again, male gender, previous birth of an infant with RDS, perinatal asphyxia, cold stress, maternal diabetes, which actually produces high levels of insulin, inhibiting surfactant production. So observe the baby for expiratory grunting, shallow breathing, nasal flaring, chest wall retractions, seesaw respirations, and generalized cyanosis. Also, you may see tachycardia with rates above 150 to 180. You may hear fine inspiratory crackles, and also see rates of breathing greater than 60. Diagnosed is based on the clinical picture, a lung ultrasound or x-ray, possible arterial blood gases. You're going to see in a chest x-ray underexpansion, hypoaeration, bell-shaped thorax, and sometimes a diffuse ground glass pattern. So this is the Silverman-Anderson index. It's an assessment scoring system that can be used to evaluate 5 parameters of work of breathing. So each category is scored as 0 for normal, 1 for moderate impairment, 2 for severe impairment. So these parameters assess chest movement. So are they synchronized? Are they lagging? Are they seesaw? The intercostal retractions, are they marked? Xiphoid retraction, again, are they marked? Nares dilation, and expiratory grunt. Normally functioning infants should have a cumulative score of 0, whereas critically ill and severely depressed infants will have scores closer to 10. The newborn needs supportive care until that surfactant is produced. So therapies include, of course, mechanical ventilation, CPAP, or positive end expiratory pressure, which is PEEP, to prevent volume loss. The use of exogenous surfactant replacement therapy to stabilize the newborn's lungs has actually become a standard of care. Another treatment is inhaled nitric oxide, improving oxygenation, reducing pulmonary inflammation, and reducing the risk of chronic lung disease. So basically, for best outcomes, it is essential that they have optimal supportive care, including maintenance of a normal body temperature, proper fluid management, good nutritional support, and support of the circulation. Therapy focuses on improving oxygenation. A lot of times they'll be in the NICU, basically applying basic principles to newborn care, such as thermoregulation, cardiovascular, nutritional support, normal glucose maintenance, and infection prevention will achieve those therapeutic goals. So some of the interventions for support, so continuously monitor. They might have arterial lines, monitor the O2 levels continuously, vital signs, acid-base status, ABGs. They may need broad-spectrum antibiotics if blood cultures are positive. Also, administering sodium bicarbonate or acetate is ordered. This will help to correct that metabolic acidosis. Providing fluids and vasopressor agents to prevent or treat hypotension, testing blood glucose levels, administering dextrose as ordered, cluster caretaking, activities to avoid overtaxing the newborn, placing the newborn in prone position to optimize that respiratory status and reduce stress, performing gentle suction to remove secretions and maintain that airway, assess level of consciousness, monitoring x-rays, maintaining a neutral thermal environment, IV feedings, possibly gavage feedings, so adequate hydration, and always encourage the parents to participate in care. Now, meconium aspiration is never a good sign. Meconium is a viscous, dark green substance. It is composed primarily of water and other gastrointestinal secretions that can be noted in the fetal gastrointestinal tract as early as 10 to 16 weeks gestation. So it's their poo for 9 months, pretty much. It is sterile. It does not contain bacteria. That is the primary factor that differentiates it from actual stool. Intrauterine distress can cause passage of the meconium into the amniotic fluid before birth. Factors that promote the passage in utero is placental insufficiency, maternal hypertension, preeclampsia, fetal hypoxia, transient umbilical compression, oligohydramnios, maternal drug use, and tobacco and cocaine use. So this syndrome occurs when the newborn inhales particulate meconium mixed with amniotic fluid into the lungs while still in utero or on taking the first breath after birth. Meconium staining of the fluid with the possibility of aspiration occurs in approximately 10 to 15% of births that are after 36 weeks gestation. Aspiration induces airway obstruction, surfactant dysfunction, hypoxia, pneumonitis. It can lead to persistent pulmonary hypertension and death. The use of surfactant and inhaled nitric oxide has led to the decreased mortality of these infants. That meconium will alter the amniotic fluid by reducing the antibacterial activity and increasing the risk of perinatal bacterial infection. Meconium is very irritating. If you've ever seen meconium, it's thick and it's almost like a firm slime. So imagining that inside of their lungs is extremely scary. So it blocks the bronchioles. It causes an inflammatory reaction. Also, it decreases production of surfactant. It impairs gas exchange, causes atelectasis. Significant respiratory distress is followed by persistent pulmonary hypertension, right to left shunting of the blood, and patent ductus arteriosus. Management will focus on appropriate oxygenation, ventilation, improvement of persistent pulmonary hypertension, and maintenance of systemic circulation. Predisposing factors for MAS is post-term pregnancy, breech presentation, forceps or vacuum extractions, ethnicity of Pacific Islander, Indigenous Australian, and African American, low APGAR, prolonged or difficult labor, maternal drug abuse, maternal infection, maternal hypertension or diabetes, fetal growth restriction, prolapsed cord, or acute or chronic placental insufficiency. You're going to observe the newborn for a barrel-shaped chest with an increased anterior-posterior chest diameter. You're going to see that it's similarly found in clients with COPD. Prolonged tachypnea, progression from mild to severe respiratory distress, intercostal retractions, and expiratory grunting and cyanosis. Chest x-rays may show patchy, fluffy infiltrates, unevenly distributed throughout the lungs. ABGs will indicate metabolic acidosis. Direct visualization of the vocal cords for meconium staining using an appropriate size laryngoscope is needed to confirm the presence of meconium below the larynx. In addition, you are going to want to cluster that newborn care to minimize that oxygen demand, maintain thermal environment, prevent complications such as hypotension, acidosis, and anemia. Pay special attention to systemic blood volume and blood pressure, administering broad spectrum antibiotics, continuing to monitor the newborn's condition. Most of the time you'll see them in NICU, and providing reassurance to mom and dad. So persistent pulmonary hypertension of the newborn. This is a cardiopulmonary disorder, and it is characterized by marked pulmonary hypertension that causes a right to left extrapulmonary shunting of blood and hypoxemia. It occurs when that circulatory system does not have a normal transition after birth. It can happen as a result of perinatal asphyxia, meconium aspiration syndrome, maternal smoking, or maternal obesity, quite a few different things. It's also been linked to maternal use of SSRIs late in pregnancy. So these moms that are on SSRIs need to weigh the risk over benefits. Pulmonary vessel pressures are elevated normally, then decrease when that newborn takes its first breath. That basically allows the blood to shunt to the lungs to increase oxygen. But if that don't happen, it causes the pulmonary vessel pressures to remain increased. So it keeps that pulmonary artery vasoconstricted, causing an elevation in the pulmonary vascular resistance. The overall result is that the newborn ends up with systemic arterial hypoxemia. You will probably see them having tachypnea within 12 hours after birth, marked cyanosis, grunting and retractions, a murmur, and you will see in an echocardiogram right to left shunting of the blood. You are going to monitor their oxygen and their perfusion, their blood pressure. You will usually see hypotension due to heart failure and hypoxemia. Immediate resuscitation and oxygen therapy is critical. Respiratory support, ABGs, airway, mechanical ventilation. A lot of times they will have sodium bicarbonate to induce metabolic alkalosis, helping to improve that oxygenation. Sometimes they will be using an ECMO, which is basically life support. clustering care to reduce stimulation, any kind of procedure such as suctioning, weighing, changing diapers, positioning. These can precipitate severe hypoxemia in these newborns because they are so unstable. So minimizing that exposure to stimulation as much as possible. So periventricular, intraventricular hemorrhage. Remember, the newborn's brain is immature, making it vulnerable to any injury. The periventricular area is the most susceptible to injury because it lines the outside of the ventricles, which are rich in capillaries and can rupture very, very easily. It occurs in up to 45% of infants whose birth weight is less than 1,500 grams and or is born at less than 35 weeks gestation. The signs vary significantly. Some may display no clinical signs whatsoever. Approximately 50% of these hemorrhages occurs by 24 hours of age and 90% by 72 hours of age. So you're going to assess for risk factors such as preterm birth, low birth weight, acidosis, asphyxia, unstable blood pressure, seizures, thrombocytopenia. If they do not administer vitamin K at birth, and the use of hyperosmolar solutions or rapid volume expansion. Key is prevention, so we need to prevent that preterm birth, keep the baby in that womb as long as possible, making sure that these moms deliver in a hospital with a NICU, correcting that anemia, acidosis, and hypotension, so it's pretty much supportive care, fluids, medications, also flexed contained positioning, keeping that head elevated while the body is flexed to prevent or minimize fluctuations in that intracranial pressure. They're going to have daily head circumferences to see if there's any swelling, clustering the care, limiting stimulation, and of course, parental support for possible long-term sequelae. Long-term neurodevelopmental outcome is determined by the severity of the bleed. Now, necrotizing enterocolitis, this is an inflammatory disease of the bowel. It has mortality rates up to 50% and is the most common among hospitalized preterm newborns. So current research points to 3 major pathological mechanisms leading to NEC. So you're going to have bowel hypoxic ischemia events, perinatal stressors, an immature intestinal barrier, abnormal bacterial colonization, and formula feeding. During perinatal or postnatal stress, oxygen is shunted away from the gut to the more important organs such as the heart and the brain. So ischemia to the intestinal wall happens, allowing bacteria to invade. The most effective prevention strategy for NEC is the use of human milk. The onset is heralded by the development of feeding intolerance, abdominal distension, and bloody stools in a preterm infant receiving feedings. As the disease worsens, the infant will develop signs and symptoms of septic shock. So you will see respiratory distress, temperature instability, lethargy, hypotension, and oliguria. Always keep the possibility of NEC in mind when dealing with preterm newborns, especially when enteral feedings are being administered. Note any respiratory distress, cyanosis, lethargy, decreased activity level, grossly bloody stools, diarrhea, bile-stained emesis. Assess for hypotension, assess for abdominal distension, tenderness, and possible visible loops of the bowel. Determine residual gastric volume prior to feeding. Also, they may have a KUB which is an abdominal x-ray. It usually confirms the presence of pneumatosis intestinalis, or air in that bowel wall, and persistently dilated loops of the bowel. They may demonstrate metabolic acidosis in blood values, increased white blood cells, thrombocytopenia, neutropenia, electrolyte imbalances, and sometimes disseminated intravascular coagulation. Attempts to improve gastrointestinal function and reduce the risk of NEC include enteral antibiotics, judicious administration of parenteral fluids, human milk feedings, antenatal corticosteroids, enteral probiotics, and slow continuous drip feedings. Bowel rest and antibiotic therapy, also IV fluids, standard care, and sometimes they may have to have surgery. Could possibly happen. Check those stools for evidence of blood. Big thing that you need to be looking for. This can cause significant family anxiety, so listen to mom and dad's worries and fears. Answer questions honestly. Inform the family that medically treated NEC is usually limited to a short period. Most of the time will resolve within 48 hours of stopping oral feedings. The amount of bowel that has necrosed, as determined during the bowel resection, significantly increases the likelihood of long-term medical problems, such as short bowel syndrome. Reassure the family that although some infants have more involved cases of NEC, the improved parenteral nutrition formulations have improved the outcomes for these babies. They may have an ostomy, so educate them on ostomy care, making sure they are interacting with their newborn. Infants of diabetic mothers. These are born to a woman with pregestational or gestational diabetes. They're at higher risk for complications, especially hypoglycemia. They remain at risk for a multitude of physiologic, metabolic, and congenital complications, such as preterm birth, macrosomia, asphyxia, respiratory distress, hypocalcemia, hyperbilirubinemia, and congenital anomalies. They can either be large for gestational age or small for gestational age. The large size arises secondary to exposure to high levels of maternal glucose that crosses that placenta into the fetal, circulation. Maternal hyperglycemia acts as a fuel to stimulate increased production of that insulin in the baby, which in turn promotes somatic growth within the fetus. Be alert for that hypoglycemia. It can occur immediately after birth or within an hour. Blood glucose levels should remain above 40. Closely assess the newborn for signs of hypoglycemia, including listlessness, hypotonia, apathy, poor feeding, apneic episodes with a drop in oxygen saturation, cyanosis, temperature instability, pallor and sweating, tremors, irritability, and seizures. Preventing hypoglycemia, providing early oral feedings within 1 hour after birth with breast milk or formula at frequent intervals, so every 2 to 3 hours. Feedings will help control those glucose levels, reducing the hematocrit and promoting bilirubin excretion. You want them pooping to get that bilirubin out. Maintain a neutral thermal environment to avoid cold stress, which will also stimulate the metabolic rate, increasing the demand for glucose. Monitoring those blood glucose levels via hill stick every hour for the first 4 hours of life, and then every 3 to 4 hours until it's stable. maintaining fluid and electrolyte balance. They may need supplementation of calcium gluconate. Assessing the newborn for signs of hypocalcemia, such as tremors, jitteriness, twitching, seizures, and high-pitched cry. Fluid therapy as ordered, monitoring those bilirubin levels, possibly instituting phototherapy if the newborn is over 24 hours old. Birth trauma. The most frequent birth injuries are bruising, fracture, and cervical plexus injuries. Also, significant birth injuries can be skull fractures, brain hemorrhage, or spinal cord damage. C-sections have contributed to the decline in birth injuries. The process of birth is a blend of compression, contractions, torques, and traction. When fetal size, presentation, or neurologic immunity complicates that process, the forces of labor and birth may lead to tissue damage, edema, hemorrhages, or fractures in the newborn. So you are going to review the labor and birth history for risk factors such as prolonged or abrupt labor, difficult or abnormal presentation, cephalopelvic disproportion, or mechanical forces such as forceps or vacuum extraction. Complete a careful physical and neurologic assessment of every newborn admitted to the nursery. Notice if there's any swelling or bruising across the suture line. Observing the eyes and face for facial paralysis. So you may see asymmetry with crying. Primarily, nursing management is supportive, focuses on assessing for resolution of the trauma or any associated complications. Provide the parents with explanations and reassurance that these injuries usually resolve with minimal or no treatment, and providing parents with a realistic picture of the situation to gain their understanding and trust. So, substance abusing moms and newborns that are born to them, the most common substances that are used: tobacco, alcohol, and marijuana. SUD results in the abuse of illicit psychoactive drugs such as cannabis, hallucinogens, opioids, stimulants, sedatives, and hypnotics. Substances exposes the fetus to the possibility of fetal growth restriction, prematurity, neurobehavioral and neurophysiologic dysfunction, birth defects, infections, and long-term development of sequelae. Infants are more likely to suffer substantiated harm, enter foster care, and have more negative child protection outcomes. The effects of fetal alcohol syndrome and spectrum disorders are well documented in the literature. Studies attest to developmental delays, intellectual disabilities, attention disorders, and psychopathologies during the child's lifetime. The National Institute on Drug Abuse suggests that over 15% of women use alcohol or illicit drugs, exposing their fetuses to their effects. Every 15 minutes, an infant is born suffering from opioid withdrawal. Drug exposure may go unrecognized in these newborns, and they may be discharged from the newborn nursery at risk for medical and social problems, including abuse and neglect. And the statistic is probably not accurate, as many women are not going to admit that they are using. So fetal alcohol spectrum disorder is the umbrella term used to describe a range of preventable conditions, birth defects, and intellectual developmental disabilities that result from mom drinking alcohol. 3 different specific findings associated are growth restriction, craniofacial structure anomalies, and central nervous system dysfunction. Neonatal abstinence syndrome compromises a constellation of drug withdrawal symptoms resulting from chronic intrauterine exposure to a variety of substances such as opioids, barbiturates, SSRIs, alcohol, benzodiazepines, caffeine, and nicotine. Newborns of women who abuse tobacco, illicit substances, caffeine, and alcohol can exhibit withdrawal behavior. These symptoms will start within 72 hours after birth and may last from 1 week to as long as 6 months. Fear of referral to child welfare agencies or the legal system has prompted women to conceal their drug abuse history. Frequently, the first inkling of drug use appears in the newborn when symptoms of withdrawal begin 48 to 72 hours after birth. Typically, the infant has been discharged by this time, unless the nurse has a high degree of suspicion that would prompt toxicology testing earlier, and absolutely you want to be assessing mom and the baby for these. Maternal history to identify risk behaviors. So if she's ever had a previous unexplained fetal demise, if she had lack of prenatal care, because clearly she doesn't want to go to the doctor because she's going to be afraid that they are going to drug test her. She may be afraid of incarceration. She may be a prostitute. She may smoke cigarettes. Fetal growth restriction, preterm births, if she has a history of STIs and or HIV, if she has a mental health disorder, if she has a history of intimate partner violence, severe mood swings, precipitous labor, if she has a poor nutritional status, abruptio placenta, history of drug abuse. The toxicology lab results will identify substances in mom and newborn. So signs of NAS, you're going to use the withdrawal acronym. So W for wakefulness. They will have a sleep duration less than 3 hours after feeding. I for irritability. T for temperature variation, tachycardia, and tremors. H, hyperactivity, high-pitched persistent cry, hyperreflexia, and hypertonus. D for diarrhea, diaphoresis, disorganized suck. R for respiratory distress, rub marks, rhinorrhea. A for apneic attacks, autonomic dysfunction. W for weight loss or failure to gain weight. A for respiratory alkalosis. L for lacrimation, so their eyes will be watering. Evidence of seizure activity and need for a protective environment in these babies, because you may see them having that. Typical behaviors in the newborn include CNS hypersensitivity, autonomic dysfunction, respiratory distress, temperature instability, hypoglycemia, tremors, seizures, hyperactive reflexes, abnormal excessive cry patterns, feeding difficulties, yawning, stuffy nose and sneezing, and GI disturbances. Toxicology screening of the newborn's blood, urine, and meconium identifies the substances to which the newborn has been exposed. Urine drug screening identifies only recent substance exposure, whereas meconium samples may reveal exposure from the second trimester to the present. So as the nurse, you're going to promote comfort, swaddling, low lighting, gentle handling, quiet environment, minimal stimulation, soft voices, pacifiers, frequent small feedings, kangaroo skin-to-skin care, vertical rocking during infant disorganization periods, and rooming in and positioning. Swaddling is huge, dimming the lights in the nursery. Erlanger East actually has a room for specifically for these babies. It's a dark room. It's quiet, has a door that you can shut so they're not hearing all the beeping and the things going on. Meeting those nutritional needs, so they do usually have impaired feeding behaviors, so they may excessively suck, they may have poor feeding, regurgitation, and diarrhea, which can cause weight loss. So they're supplemented with a high calorie formula. Make sure you're keeping them upright when feeding them to prevent aspiration and to facilitate that rhythmic sucking and swallowing. Breastfeeding is encouraged unless the mother is still using drugs. Preventing complications, so pharmacologic treatment is warranted if conservative measures such as swaddling and decreased environmental stimulation are not adequate. A lot of times medications used in these newborns going through withdrawals include an opioid such as morphine or methadone, and sublingual buprenorphine or phenobarbital or clonidine. The newborn is at risk for skin breakdown, weight loss, diarrhea, dehydration. Providing meticulous skin care and protecting the newborn's elbows and knees against friction and abrasions are very important. Promoting parent-newborn interaction. The mom may feel guilty about the newborn's condition. Many of these newborns are unresponsive and have disorganized sleeping and feeding patterns. They can be easily overstimulated and irritated when they're awake. This can make parent-newborn interactions difficult and frustrating, leading to possible detachment and avoidance. So, nursing support, which includes a description of symptoms and their management, is vital if maternal-infant attachment is to occur and potential neglect or abuse is avoided. Hyperbilirubinemia. Bilirubin is the end product of hemoglobin breakdown. Typically, the total serum bilirubin level rises over the first 3 to 5 days and then declines. So after that umbilical cord is cut, the mother's liver no longer will filter out the bilirubin, so the newborn's immature liver has to. The bilirubin levels will rise due to the increased red blood cell breakdown, as they don't need as many red blood cells once their blood is oxygenated by breathing. Decreased removal of the red blood cells due to the immature liver unable to produce the enzymes needed, and the bowel is not excreting the bilirubin as it is supposed to. Physiologic jaundice happens in the 3rd to 4th day of life. Basically, early onset breastfeeding jaundice is due to ineffective breastfeeding practices, also the delay of meconium. So early frequent feedings can provide the newborn with the calories and fluid volume they need to decrease those bilirubin levels. They need to be fed at least 8 to 12 times in the first few days. And the best way to judge successful breastfeeding is to monitor the infant urine output, stool output, and weight. Late onset breastfeeding jaundice, bilirubin usually peaks in the first 6 to 14 days of life, and it's usually when the mature milk begins to replace colostrum, and it could possibly be due to that change in milk composition. Now, pathologic jaundice, this manifests within the first 24 hours of life. Never good. Never good. Requires intervention to prevent acute bilirubin encephalopathy or kernicterus. Kernicterus is a type of brain damage that can result from high levels of bilirubin in the baby's blood. It can cause cerebral palsy and hearing loss, problems with vision and teeth, and sometimes can cause intellectual disabilities. Acute bilirubin encephalopathy describes the effects of hyperbilirubinemia in the first weeks of life. It's devastating. It can lead to death or lifelong neurodevelopmental handicaps. It is tragic because it is completely preventable. Clinical signs include lethargy, poor feeding, high-pitched cry, poor tone, a poor moro reflex with incomplete flexion of the extremities, and a high-pitched, I already said a high-pitched cry. As symptoms of acute bilirubin encephalopathy worsen, the newborn progresses to apnea, seizures, coma, and death. Now, chronic bilirubin encephalopathy, or kernicterus, is a preventable neurologic syndrome that results in the deposition of unconjugated or indirect bilirubin in the basal ganglia and brainstem nuclei. The 4 clinical manifestations, so they're going to have a movement disorder, so athetosis, dystonia, spasticity, or hypotonia. They're going to have auditory dysfunction or deafness, oculomotor impairment, and dental enamel hypoplasia of deciduous teeth. The unconjugated bilirubin will enter the brain and acts as a neurotoxin, causing long-term neurological sequelae. Now, Rh isoimmunization or ABO incompatibility. This is the most common condition that is associated with pathological jaundice. It is the hemolytic disease of the newborn secondary to the incompatibility of the blood groups of mom and the newborn. The most frequent conditions are Rh factor and ABO incompatibilities. Significant jaundice in the newborn less than 24 hours of age should be immediately reported to the physician because it may indicate a serious pathological process. So you're going to assess for risk factors such as polycythemia, significant bruising, or cephalohematoma, which increases bilirubin production. If infections such as toxoplasmosis, hepatitis B, rubella, cytomegalovirus, or herpes simplex virus. Also medications that are used during labor and birth such as Valium or diazepam or oxytocin or PIT. Also, you're going to note if they are premature, if their gestational age is between 34 to 36. Of course, ABO incompatibility, delayed cord clamping, which will increase that erythrocyte volume, hypoxemia, and respiratory distress experienced at birth. Also, again, male gender. So you're going to assess the skin, the mucous membranes, the sclera, the body fluids, the tears, and the urine for a yellow color. You can detect jaundice by observing the infant in a well-lit room and blanching the skin with digital pressure over a bony prominence. Typically, the jaundice will begin on the head and gradually progresses to the abdomen and extremities. You're also going to inspect for pallor, excessive bruising, and dehydration. Now, signs of Rh incompatibility, you're going to see ascites, anemia, congestive heart failure, edema, pallor, jaundice, hepatosplenomegaly, polyhydramnios, thick placenta, and dilation of the umbilical vein. To reduce bilirubin levels, you are going to encourage early initiation of feedings to prevent hypoglycemia and provide protein to maintain the albumin levels that transport that bilirubin to the liver. Making sure the newborn is eating every 2 to 3 hours. Encouraging the mother to breastfeed 8 to 12 feedings per day. Also supplementing breast milk with formula to supply protein if those bilirubin levels continue to increase. Also, phototherapy is used to convert unconjugated bilirubin to the less toxic water-soluble form that's excreted in the poop. Phototherapy uses special lights that are placed above the newborn or a fiber optic blanket that is placed under the newborn and wrapped around him or her. And it involves blue wavelengths of light to alter that unconjugated bilirubin in the skin. You're going to place the newborn under the lights, exposing as much skin as possible. Cover the genitals and shield the eyes to protect the areas from becoming irritated or burned when using those direct lights, turning the newborn every 2 hours, removing the newborn from the lights only for feedings, maintaining that neutral thermal environment, decreasing energy expenditure, and assessing their neurological status frequently. Assessing the temperature every 3 to 4 hours is indicated. Monitor fluid intake and output closely. Evaluate daily weights. With feedings, remove the newborn from the lights and remove the eye shields to allow interaction with the newborn. Monitoring stool for consistency and frequency. Unconjugated bilirubin excreted in the feces will produce a greenish appearance, and typically those stools are going to be loose. Make sure that you're providing meticulous skin care, supporting breastfeeding, placing infants on their back to expose as much naked skin as possible. And then if the total serum bilirubin level remains elevated after phototherapy, an exchange transfusion with albumin is administered before the transfusion. This is the quickest method for lowering serum bilirubin levels. These exchange transfusions are a high-risk procedure and should be performed only when the benefit offsets the risk. In the presence of hemolytic disease, severe anemia, or a rapid rise in that bilirubin level, it is always recommended for an exchange transfusion. This removes the newborn's blood and replaces it with non-hemolyzed red blood cells from a donor. During this transfusion, you're going to monitor their cardiovascular status continuously. Serious complications can arise with this, such as acid-base imbalances, infection, hypovolemia, and fluid and electrolyte imbalances. It is used only as a second-line therapy after the phototherapy has failed. Nurses can help the parents to understand the diagnostic tests. They are the ones that will be giving discharge instructions to the families. Teach them about jaundice and the potential risk. Show parents how to identify newborn behaviors that might indicate rising bilirubin levels, and such as lethargy, sleepiness, poor muscle tone, floppiness, poor sucking or lack of interest in feeding, high-pitched cry or irritability. Teach the parents that how to assess them for signs of jaundice, because a lot of times they will not have this until after the newborn is discharged. So make sure that they do know the signs that they need to let their primary care doctor know. Newborn infections. So neonatal sepsis could be bacterial, fungal, or viral. Newborns are more susceptible to infection due to their immature immune systems and, of course, their fragile skin barrier. So it's classified as congenital or intrauterine. This is acquired in utero before birth. Early onset or perinatal period, so this is shortly before or after birth, usually from mom's genitourinary system. Late onset is transmission in the nursery through healthcare workers or HIV from breast milk. Nursing assessment, you are going to assess risk factors, non-specific symptoms, elevated C-reactive protein, and if they have positive cultures. Assess them for temperature instability, hypotension, tachycardia, pallor or duskiness, hypotonia, cyanosis, poor weight gain, seizures, rash, petechiae, jaundice, grunting, nasal flaring, poor feeding, abdominal distension. You may see leukocytosis or leukopenia, elevated C-reactive protein levels that may indicate inflammation. Blood, cerebrospinal fluid, and urine cultures are indicated to identify the location of the infection. Early recognition and diagnosis are essential in infections. Antibiotic therapy is usually started before lab results identify the infecting pathogen, making sure that you're going to screen all newborns daily for signs of sepsis. You're going to make sure all the staff are thoroughly washing their hands, monitoring and supporting nutritional status, circulatory support with fluids and vasopressors, and such. So primary disease prevention is the major focus for us as nurses. Now, congenital conditions, these are the structural anomalies present at birth caused by genetics or environmental exposure. These can arise from many etiologies. They may be inherited or sporadic, isolated or multiple. The U.S. Public Health Service recommends that all women of childbearing age take or consume 400 micrograms of folic acid daily to reduce the risk by 70%, because most issues happen before the woman even knows that she is pregnant. That is 3 to 4 weeks after conception. And most of the time, the neonate will have more than just one anomaly when genetics are involved. Esophageal atresia is when the esophagus either does not attach to the stomach or the esophagus is narrowed in one portion. Tracheoesophageal fistula is when the esophagus connects to the trachea. Usually, no cause is identified. Some can be attributed to genetic factors, infections, and teratogens. It's thought to result due to incomplete separation of the lung bed from the foregut during early fetal development. Mom usually will have polyhydramnios because the fetus cannot swallow the amniotic fluid in utero. And after birth, the newborn can have frothy and copious bubbles in the mouth and nose along with drooling. Abdominal distension develops as air is bubbling up in the stomach. The classic sign is the 3 C's: coughing, choking, and cyanosis if feeding is attempted. This increases the risk for pneumonitis and atelectasis due to aspiration of food and secretions. You're going to prep these babies for x-ray, ultrasound, or MRI. Prep them for surgery if the newborn is stable. Initiate nothing by mouth status. Elevate the head of the bed 30 to 45 degrees to prevent reflux and aspiration. IV fluids, fluid and electrolyte balance, maintaining the patency of the orogastric tube, which is attached to low suction, having oxygen and suctioning equipment readily available. And then for post-op care, immediate surgical management involves creating a gastrostomy opening for a tube for feeding and continuous suctioning of the blind esophageal pouch. Surgery consists of closing the fistula and joining the 2 esophageal segments. So you're going to closely observe all of their body systems, expect to administer TPN and antibiotics until the esophageal anastomosis has been proven intact and patent. Usually oral feedings will begin within a week after surgery. Closely assess the newborn during feeding and report any difficulty with swallowing, and of course, parent education. An omphalocele is a defect in the umbilical ring, allowing the abdominal contents to emerge into an external sac. These defects vary in size, may be limited to bowel loops, or may include the entire GI tract and liver. Gastroschisis is a herniation through the wall at the umbilicus, but it does not have a sac protecting the organs. So this exposes them to amniotic fluid, making these organs thickened, swollen, and inflamed. Despite surgical correction, feeding intolerance, failure to thrive, and prolonged hospital stays may occur in newborns with this anomaly. A pediatric surgeon must be available at every delivery of these neonates. Usually they have already been diagnosed at a prenatal ultrasound. Maternal history may have factors such as maternal illness and infection, drug use, smoking, and genetic anomalies. Nursing management focuses on preventing hypothermia, maintaining perfusion to those eviscerated abdominal contents by minimizing fluid loss and protecting the exposed abdominal contents from trauma and infection. You're going to place the infant in a sterile drawstring bowel bag that maintains a sterile environment for the exposed contents. It allows visualization, reduces heat and moisture loss, and it allows heat from the radiant warmers to reach the infant. Be alert for vasculature changes, such as change in color or decrease in temperature, which can strangulate the bowel. And parents may be afraid to touch the newborn. This is always something that we need to encourage moms and dads to do. Now, an imperforate anus is a very rare birth defect. The rectum may end in a blind pouch that does not connect to the colon, or it may have fistulas or openings between the rectum and perineum. Elimination of feces may not be possible until surgery is performed. They're classified as high and low types. So for the high type, the newborn will have surgery in stages involving a colostomy. For a low type, surgery includes a fistula, closure of the fistula, creation of an anal opening, and repositioning of the rectal pouch into the anal opening. You may see abdominal distension and vomiting bile. So goals are gastric decompression and surgery, IV therapy and antibiotics, and preparing the parents that there will probably be an ostomy involved. Bladder exstrophy. The bladder and related structures are turned inside out through an opening in the abdominal wall. A malformed urethra may be present in females, and then in males you may have an unformed or malformed penis or normal penis with epispadias. Complications include UTI, and treatments is usually surgery, sometimes including an ostomy. Question: is the following statement true or false? Neonatal asphyxia commonly resolves within 72 hours after birth. That is false. It requires immediate resuscitation measures and may lead to hypoxic ischemic encephalopathy. Stop. Is the following statement true or false? The underlying problem associated with meconium aspiration syndrome in utero involves hypoxic stress. The answer is true. Meconium may be passed in utero secondary to hypoxic stress. Which of the following would the nurse expect to assess in a newborn with necrotizing enterocolitis? The answer is C, abdominal distension. So a newborn with necrotizing enterocolitis would exhibit abdominal distension and tenderness with bloody stools, bilious vomiting, feeding intolerance, lethargy, sepsis, apnea, and shock. And seizures are not associated with NEC.